So today, Megan Kenny, Naomi McCormick, Emily Dubé, Kaylee McKay, Rebecca Barrett, and myself, Madeline Johnson, will be discussing burns. So a burn is defined as an injury to the tissue that is caused by either chemicals, electrical currents, radiation, or heat. The results of the burn depend on the temperature of the burning agent, the amount of time the tissue had in contact with the agent, and the type of tissue that was burned. Burns are oftentimes preventable and can happen from simple household things like ovens, microwaves, boiling water, steam, or grease from cooking.
Okay, so the three interrelated concepts that we chose were tissue integrity, fluid and electrolytes, and infection. So the reason we chose these were tissue integrity is probably the main one that applies to burns. And as a result of a burn, our skin goes through a multitude of different chemical and mechanical events. With extensive burns, tissue integrity can become completely lost. And then we chose fluid and electrolytes because burns can cause a disruption of fluid and electrolytes by third spacing of fluid. And then we chose infection because the risk for infection is high when treating a person with burns, and sterile technique is important. And there's more interrelated concepts, but we just chose to focus on these three because we felt that they applied the most.
So there are different types of burn-related injuries. One of them is thermal burns. This occurs when skin touches something hot, for example, a fire. It is the most common type of burn injury. This tends to happen when people are using highly flammable items or objects. Scalding is also a different type of thermal burn. So this results from contact with a boiling substance or steam. The severity of the injury will depend on the length and degree of the heat of the exposure. We also have chemical burns. So this occurs when skin touches something that is highly acidic or basic. Alkalotic burns can result from cleaning products that are used for industrial cleaning, but it can also result from cleaning products that are used for cleaning ovens and drains. So alkalis stick to tissue, which makes them more challenging to manage. So alkali burns end up causing the breakdown of proteins of the skin. Chemical burns can also result from contact with organic compounds, such as gasoline. Severity is dependent on the strength of the chemical and the duration of exposure. It can also be inhaled, which can cause injury below the glottis. So we have electrical burns. This type of burn results from an electrical current. Different parts of the body have different tissue density, which will affect the amount of resistance the body will pose against the electrical current. For example, bones have a higher density than blood vessels. Currents are also able to pass through the organs of the body, which is especially life-threatening if the current passes through any of the vital organs, such as the heart, kidneys, or even the lungs. Severity will depend on voltage, resistance, and duration of the exposure. Smoke and inhalation injury is typically caused by a thermal injury. This is caused from breathing poisonous or harmful chemicals or hot air. This causes damage to the respiratory tract tissue. Smoke inhalation injury can result in pulmonary edema, and it can also compromise the airway. This typically results in the first 24 hours, 12 to 24 hours after the exposure. It can also cause carbon monoxide poisoning and injury above the glottis. This is why the assessment is crucial. We need to listen for hoarseness, and they will also have pain when swallowing. So getting our assessment done within the first 12 to 24 hours after that exposure is very important. So cold thermal injury, we have frostbite. And so this is caused from an exposure to an ambient temperature for an extended amount of time. We also need to consider the condition of the person's clothing, if they were wearing wet or dry clothing, and if they've had any contact with metal surfaces. There's formation of crystals in the tissue cells, which ends up destroying the cell membranes, and it results in edema. This also makes the skin feel very crunchy. So we also have superficial frostbite, which typically occurs on the nose, ears, toes, and fingers, and it is painful. But deep frostbite, however, affects muscle, bones, and tendons. And when you have deep frostbite, you are insensitive to touch. Regardless of which type of frostbite, rewarming is extremely painful, so it is very important to have our patient on analgesic to prepare for that pain.
Okay, so for classification of burns, I'm going to start with the 3 layers of the skin. So the skin is divided into 3 layers: the epidermis, dermis, and subcutaneous tissue. The epidermis is the thin outer layer of non-vascular skin that is the thickness of a sheet of paper. The epidermis is made of epithelial cells that act as a protective barrier to the skin, contains fluid and electrolytes, helps with temperature regulation, and keeps harmful agents from entering the body. The dermis, which is the second layer of skin, is the layer of skin that is 35 to 45 times thicker than the top thin layer of skin. Connective tissues with blood vessels and highly specialized structures are found in the dermis layer. These connective tissues is where you can find hair follicles, nerve endings, sweat glands, and sebaceous glands. The subcutaneous tissue is the innermost layer of skin, and this layer is where major vascular networks, fat, nerves, and lymphatic vessels are found. This inner layer is an insulator for heat of the underlying structures such as muscles, tendons, bones, and internal organs. So burns are classified as first, second, third, or fourth degree. A more precise way that burns are classified is the classification according to the depth of the burn, which is either partial thickness or full thickness burn. So a first degree burn, these burns are superficial, only the outermost layer is affected. The burn site will be red, painful, and dry. There is no blisters present, and long-term damage is rare. Most of the damage consists of an increase or decrease to the color of the skin of the affected area. Second-degree burns are damage to the epidermis and some of the dermis layer of skin. The site of the burn will have blisters and it will be red in color. The site may be swollen or painful. And third and fourth degree burns. With a third degree burn, both the epidermis and dermis are destroyed. And in some cases, underlying bones, muscles, and tendons can be damaged, which will be classified as a fourth degree burn. The site of the burn will be white or charred and has no sensation in the area due to the destruction of nerve endings. So with a partial thickness burn, it includes first degree burns and second degree burns. With a partial thickness burn, there's different amounts of damage to the epidermal and dermal layer of the skin. Regeneration is possible because there are some viable skin elements still present. And full thickness burns, these include third and fourth degree burns. Full thickness burns involves all skin elements and subcutaneous tissue. There's a possibility of damage to underlying muscles, tendons, and bones. Shafts of hair follicles, sweat glands, and sebaceous glands have skin reproducing cells in them, and with the significant damage to the dermis layer of the skin, with a full thickness burn, there's not enough of these skin cells remaining for regeneration to occur. An alternative source of skin is needed if regeneration cannot occur. So for the location of burns, the location of a burn relates to the severity of a burn. Burns to the face, neck, and circumferential burns to the trunk or back can cause a mechanical obstruction. These mechanical obstructions are caused by edema and leathery, devitalized tissue. This edema and damaged skin tissue can inhibit the respiratory function of the burn victim. Other injuries that may affect the patient's breathing are inhalation injury or respiratory mucosal damage. Burns to the hands, feet, joints, and eyes are severe due to the patient's inability to perform self-care and the possibility of damage affecting future function. When the hands and feet are burned, it is a difficult healing process. This healing process is difficult due to the superficial vascular and nerve supply systems that are present in the hands and feet and the need for function of the hands during the healing process. Burns on the ears and nose are more susceptible to infection, and this is because the skin on the ears and nose is very thin, and when it's burned, underlying skeleton is usually exposed. Burns to the buttocks and perineum are at a high risk of infection due to the contamination from urine and feces, and when a circumferential burn occurs on an extremity, there can be circulatory compromise distal to the burn, which can cause neurological impairment. And for the two most common guides used to determine the total body surface area, these are known as the adult Lund-Browder chart and the adult rule of nines chart. The Lund-Browder chart is more accurate because it takes into consideration the patient's age in proportion to relative body area and size. The rules of nines is easier to remember, so it is used in the initial assessment of an adult's burn injury. These charts measure the percent of the body that has a burn present. The rule of nines has a set percentage for each body part, no matter the age or size of the patient, and the Lund-Browder chart takes into consideration the patient's age and body size. And if the burn is irregular or an odd shape, the palm of the hand is used to measure the burn and is approximately 1% TBSA.
So phases of burn management, there are 3 phases which are defined as emergent, acute, and rehabilitative. There's also a pre-hospital phase, which includes care that is provided before the arrival of the hospital to the hospital, and then priority intervention is usually to stop the burning process, if not done so already. If the patient is unresponsive, the interventions are prioritized as circulation, airway, and then breathing. And if the patient is responsive, the interventions are airway, breathing, and circulation. So for circulation, you assess by checking for pulses. For airway, you can check for patency of nostrils and tongue to observe for any soot or any obstructions. You can check for discoloration of both the nasal and oral membranes. And for breathing, you can assess the respiratory rate and identify if ventilation is adequate. This pre-hospital phase, the care is often dependent on who is at the scene at the time of the burn. So depending if it's a paramedic or a family member, but often if it's a small thermal burn, you can place a cold, damp cloth. This helps provide comfort as well as minimize the depth of injury before actually arriving to the hospital. The emergent phase, this phase can also be known as a resuscitative phase because this is when life-threatening implications are resolved and require immediate treatment. The primary concerns throughout this phase are the patient developing hypovolemic shock and edema. So hypovolemic shock occurs when there is a shift of fluids out of the blood vessels due to an increase in capillary permeability, and this can happen after only 20 minutes of the burn injury occurring. This phase normally lasts up to 72 hours after the burn, and it will end when diuresis and fluid mobilization takes place. When fluid moves to areas that normally don't have fluids, this can be called as third spacing, and this creates exudate and blisters that are very common in burns. And patient survival really depends on the assessment and interventions that are implemented throughout this phase. So the next phase is acute phase, and this is also known as the wound healing phase. This begins following the movement of the extracellular fluid. So wound healing begins when the white blood clots surround the site and phagocytosis occurs. Necrotic tissue begins to slough and fibroblasts form collagen, which results in granulation tissue. So throughout this phase, the priority prevention is infection. And this phase will end when the wound is healed or completely covered by a skin graft if necessary. So throughout this phase, you want to do wound care, excision and grafting if necessary, pain management, physiotherapy, nutritional therapy, and psychosocial care. And then the last phase is the rehabilitative phase. Throughout this phase is when the patient is able to perform self-care activities and become a functional role in society, kind of gives them more of a sense of normality in their life. It's important to have family members or caregivers involved in this phase because patients will often go home with small or not completely healed wounds. So education needs to be provided and hand-on instructions for dressing changes and just wound care in general if necessary. And sometimes home care nursing services will be provided if necessary. Sometimes reconstructive surgery or cosmetic surgery may be discussed and or implemented in this phase. And it's important to address the patient's psychological health because after going through something so traumatic as a burn, it can have a huge effect on your self-esteem. So you want to address any feelings of anxiety, fear, or depression that the patient may be feeling.
Okay, so I'm just going to take a look at some labs and diagnostics that we can do for burn patients. And because a burn is a physical trauma, there isn't one specific test to diagnose a burn, but there are tests that we can do to measure how bad the burn is, the severity of it, and how well the client is reacting to treatments they may be receiving. So the first one I'm going to talk about is a bronchoscopy, and that is to be done 6 to 12 hours after injury. As we've heard already, a huge concern for burn patients is inhalation injuries. So a bronchoscopy basically just takes a scope and looks into their airways and makes sure there is no burns inside of their airways and they haven't suffered any damage from smoke or anything like that that they may have had during their burn. The next one that we're going to take a look at is an arterial blood gas, and that is done to measure red blood cells' ability to carry oxygen throughout the body. And that is affected because the patient may suffer from carbon monoxide poisoning or other chemicals during their burn that affect the red blood cells' ability to carry oxygen through the body and perfuse. And then also we're going to take a look at cultures and sensitivities for wounds because we know that they're at a high risk for infection. And so it's important to get those cultures and sensitivities so we can specifically treat whatever infection they may have. Okay, so some more labs and diagnostics we have. We're going to monitor for immune changes. So with burns, we have a widespread across the body inflammation from the injury. So all of the immunal changes that we're going to see like elevated levels in those. And also we're going to monitor for those because our patients are at high risk for infection. Also, we're going to monitor their serum electrolyte levels. As we're going to see in just a minute, their electrolytes and fluids are all out of balance. So it's really important to know what those levels are because also the treatments that we're going to give are going to vary on that. So if they have, for example, low sodium, treatment is going to differ from if they had high sodium and things like that. Yeah.
So I'm going to speak on airway management. So that is one of the treatments available for patients who have burns. So one form of this is to intubate the patient. And this is only done when there are major burns involved, especially to the head and the neck. So the intubation normally occurs during the first couple of hours as to avoid emergency tracheostomy. So once the patient is intubated, they will then be put on a ventilator. So the arterial blood glucose test is done to be able to give the correct amount of oxygen to this patient depending on the amount of burns that they have. So once the patient is intubated and the swelling starts to go down, they will be extubated, and that normally occurs after 3 to 6 days of the intubation. And then 100% humidified air is another form of treatment for this, and that is used when the burns are not as extreme and the patient doesn't require intubation. So things to help with this would be deep breathing and coughing to encourage them to do that about every hour to help maintain airway management. And then patients also should be placed in high Fowlers unless there's contraindications and repositioned every couple of hours to make sure there's no more tissue damage. Fluid therapy is another form of treatment that is available for the patient. Fluid therapy is normally done with a large bore IV access. They use 2 of these in patients with 15% TBSA, which is the total body surface area that is burned. And the large bore IV access is done to administer fluids, and they can also administer medications through there. If the patient has 30% TBSA burns, a central line is needed. The amount of fluid resuscitation needed is determined by a standardized chart that measures the extent of the wound. So depending on how much of the body is burned and how deep they are depends on how much fluid is needed. The fluids are replaced with either crystalloid solutions, colloids, or a mixture of both, depending on, as I've said again, the percent of burned body. And then there is a formula that is used for fluid replacement, and that is called the Parkland or Baxter formula. And so how this is used is it is 4 mils of lactated Ringer's solution per kilogram of the patient's body weight per the percentage of TBSA burned, which equals the total fluid resuscitation for the first 24 hours of the burn. So analgesia is one of the drug management therapies that is used for patients who have burned. It is used to relieve the pain. So there are opioid and non-opioid options depending on the severity of the burns and the pain that the patient is experiencing. So most non-opioid analgesics inhibit the synthesis of prostaglandin peripherally and centrally, and it depends on the different effects. Whereas opioid options normally work by binding to the opioid receptors in the central nervous system. The opioid acts as an agonist of the endogenously occurring opioid peptides. The perception of and response to pain is altered as a result of this. And obviously the pain is whatever the patient is feeling. Examples of these are morphine, and there's also sustained release morphine, hydromorphone or sustained release hydromorphone, fentanyl, as well as acetaminophen, ibuprofen, adjuvant analgesics, and pregabalin. So another type of drug that is used for patients with burns would be the sedative hypnotics. So these drugs create antipsychotic and sedative effects. For example, quetiapine and haloperidol. Those are drugs that would create those type of effects. Whereas some decrease anxiety. So lorazepam would be one that would just decrease the anxiety of having the burns and seeing them and the response to the therapy. And then there are also drugs, the sedative hypnotics, that create short-acting amnesic responses. So those drugs would be the midazolam and the ketamine. lastly, there's a couple of other drugs that work towards helping the patients who have burns, and these drugs sometimes aren't used with everyone. It just depends on how the patient is coping with them. So antidepressants would be one. These medical therapies are used to improve the patient's mood by decreasing their depression in case they're in the hospital for therapy for long periods of time or different things like that. So there's a couple examples for that, which would be venlafaxine and citalopram. Anticoagulants, so these prevent venous thromboembolisms and are the reason that patients use these therapies. So examples of these would be the enoxaparin and heparin. So lastly, there's the gastrointestinal support. There are two mechanisms of action for these supports. So the ranitidine and the esomeprazolone, those decrease the acid in the stomach as well as lower the risk of the patient developing a curling ulcer. And then aluminum and magnesium hydroxide works to neutralize the stomach acid. So both of these supports are working with the stomach acid to make it less acidic for the patient.
Another form of therapy is nutritional therapy, and this is a huge aspect of their therapy because the body requires more nutrients and things like that to be able to heal itself from the injury that it sustained. So proper nutrition, it decreases the risks of complications and increases wound healing. Oftentimes, high calorie and nutrient and protein dense diets are suggested in the early stages of therapy. So patients who are not intubated with a total body surface area of less than 20% can typically meet their nutritional needs PO, so by mouth. And so really just teaching and making sure they're getting the correct amount of nutrients is important in those patients. And then patients who are intubated or with burns greater than 20% of their body surface area require nutritional support. So either tube feeding or supplemental things like that. Oftentimes patients suffer from paralytic ileus after burns, so their bowel kind of shuts down. So it's important not only to be putting food and nutrients into their body, but also for suctioning and things like that, they may need to have a tube put in as well.
Did it again. So now that everyone's gone over their parts, I'll kind of just try to sum everything up with the nursing process. So that would be assessment, diagnosis, planning, implementation, and evaluation. So starting with assessment, like Maddie said, we need to assess the ABCs immediately after injury. So make sure that their airway is clear, make sure that they're breathing, and make sure that they're perfusing. And then we would conduct a skin examination. So that's estimating approximately how much of the body is burned. So using the total body surface area and the rule of nines, like Kaylee said. And then we assess for the size, shape, color, and drainage from the wound. So if there's any exudate or pus or anything like that, which would be caused by a fluid spacing, or third spacing, sorry. And then notes any signs and symptoms of fluid and electrolyte imbalances. So that can be done too with the diagnostic test that Naomi was talking about. And then note signs and symptoms of infection Someone mentioned that already as well. So like I said earlier, pus, redness, swelling, pain, and assess for signs of dehydration too. That's a big one because of the fluid shifting and all that. So look at their mucous membrane, see if they're dry or moist. And then look for sunken orbitals and other things that would indicate dehydration. And then, so for the nursing diagnoses, these 4 I picked just because I thought they would be most priority. So I mentioned impaired physical mobility related to pain, discomfort, decreased strength and ability. So if someone has burns over like a great percentage of their body, they're not going to be moving as much as opposed to a person who maybe has a burn on their arm or their face. So yeah, just making sure that you can rehabilitate them if that is the case. And then for the next one, I picked impaired skin integrity. So this is related to disruption of the skin surface with disruption of the layers, like Kaylee talked about. And then the next one is risk for infection. So this risk factor is the destruction of the skin barrier. So it's important to make sure that we're using sterile technique when we're caring for the wounds and dressings and stuff like that, if there is any. And especially if a patient has any skin grafting done, you need to make sure that it doesn't get infected. And then the next one is risk for deficit fluid volume. So the risk factor here would be the loss of fluid through abnormal roots. So that would be the third spacing that's going on. And I have some more on the next slide too. I didn't go into as much detail with these ones just because I picked the priority ones in the last slide. So for these, I just picked risk for ineffective airway clearance. And that would be like, and Naomi was talking about how your throat can be affected by inhalation of carbon monoxide and other chemicals. And then deficient knowledge, disturbed body image. So self-esteem is a big thing for people who have experienced burns and they have them on their face or on a large percentage of their body. It definitely affects your body image. Fear or anxiety, that's kind of related to the same thing. And then imbalanced nutrition, less than body requirements. So when people have large burns all over their body and they can't eat by mouth, they're on IV fluids and stuff like that. They're getting a lot less than they need for their body to function normally. And then risk for ineffective tissue perfusion. So if they're unable to breathe as well, you know, their body's not perfusing as well as it could be. And then acute pain is a big one too. Obviously they're in a lot of pain. So we need to make sure that we're medicating them for that pain. And yeah. So planning, these are kind of the outcomes that we want the patient to achieve, and they differ for different patients, like whether they have burns all over their body or just little burns, but I just picked some overall ones. So you want the patient to demonstrate wound healing, tissue regeneration, and remain free of infection. I think that's probably the most important one. You want the skin to kind of go back to normal or as close to normal as it can be. And then you want the patient to maintain or increase strength and function of affected area. So that would be those patients who have like impaired physical mobility. And then you want the patient to demonstrate improved fluid balance, so increased urinary output, stable vital signs, and moist mucous membrane. So you can help move that along by giving them IV fluids and making sure they're taking in the amount of nutrition that they can. And then patient will be able to voice awareness of preventative measures. And this is kind of for the patients who suffer from smaller burns from accidents like being burnt on a stove or being around open fires and stuff like that, and they accidentally get burned that way, rather than the patients who have large burns over their body from like house fires and stuff like that. And then for the interventions, I couldn't list them all because there's so many for each nursing diagnosis, but a few listed here are monitor vital signs as indicated. So whether it be like every hour in the beginning or like moving on from that, you could do it every 4 hours or whatever is indicated. And then document size, color, and depth of the wound. Note any swelling, drainage, like pus, exudate, stuff like that. And then provide burn care and infection control measures. So whether that be dressing changes, or there is no dressing and you're just caring for the wound as is, or if there's any grafting, you want to take care of that using sterile technique, like I said earlier. And then you want to maintain the wound covering as indicated, so kind of adding on to what I just said. If there is a dressing, you want to make sure you're taking care of that the right way. And if they're going to get grafting and they haven't had it yet, you want to prepare for that if it's necessary. You also want to keep skin free from pressure to avoid those pressure injuries that can happen. So if there's a patient who has large burns all over their body and they're having trouble moving and stuff like that, you want to help them reposition and stuff like that so they don't get pressure injuries on them. So turning the patient. And that can be difficult for a person who suffers a lot of burns on their body, so take precaution there. And then note circulation and sensation of limbs and digits. So this would kind of be earlier on when you're assessing the patient and charting. You want to note if they're still perfusing, right? So note circulation. And then medicate for pain, that's a big one. So they're going to be in a lot of pain. So you want to make sure that you're using those analgesics and medicate also for the anxiety that Becca was talking about. Monitor urinary output. So in a patient with large area that's burned, oftentimes they'll have third spacing, and this can affect urinary output because they'll be dehydrated. So you want to make sure you're monitoring how much they're putting out. And then you want to rehydrate them with IV replacement fluids. And also, like Naomi was talking, you want nutritional therapy. If they can take it by mouth, you want to do it that way. And if they have large areas covered and they can't take it by mouth, you want to make sure that you're getting them those supplemental ways for nutrition. And then just a little part on evaluation here. You just want to note their progression towards their goals, modify the plan of care if needed, and assess patients' knowledge of burns and how they can prevent them. And that's it.